4th and 6th knot are locked, and you cut it. And then you repeat the same step with 2 more anchors. This is the lowermost anchor. And if you see here, I'm passing this suture further down inferiorly for the lowermost anchor, because I want to tackle the inferior part the most in recurrent anterior dislocation of shoulder, not just the anterior part of the soft tissue. And there I have repaired the whole antero-inferior capsule. I can see a large bumper effect. And then I can pass another suture at the posterior inferior part of the glenoid. So what are the problems? Why is arthroscopic Bankart repair getting into disrepute? I think there are certain problems. One is the inadequate, improper technique of tightening the inferior capsule. I do believe that a lot of Bankart repairs arthroscopically are not done properly. The second factor, I think, is there is a very poor quality of capsule in about 1/3 of these patients, which perhaps is genetic. So they are predisposed to failure, especially if these 30% with poor capsule are going to be involved in contact sports. We all know that bone loss, which is significant, is a contraindication for arthroscopic Bankart repair. I'm not against lethargy. I think it's a useful operation. One has to know. I do it all the time, but my incidence is in less than 10%, because I don't see such large glenoid bone loss in that many number of cases. And I'm not keen to do a lethargy in patients who do not have significant bone loss. Those who are keen for arthroscopic lethargy, this is the slide for them. Do not forget that capsule is divine. It has proprioception, it has mechanoreceptors. I would hate to destroy that capsule as they do in arthroscopic lethargy procedure. A Bankart repair is not such an easy operation. You have to be careful. Things can go wrong. Here is a reaction to this is the 2nd generation of anchors, where there was a high tissue reaction. The patient had pain, inflammation. Eventually, it subsided with anti-inflammatory in time. But you got to be careful, just as any other operation. In summary, arthroscopic Bankart repair with suture anchors for traumatic anterior dislocation, I think, is a successful technique, and the results are equal to open Bankart repair. But I agree with Professor Boker that you do need to have expertise and know-how of open technique, because that is going to be required in your armamentarium. And the future research, I think, should be not addressing so much of bone loss, but more towards quantifying the mechanoreceptors, the quality of the capsule. And that's the work which is going on at the moment. I end this talk with what my daughter calls is that's a cartoon film. This I made more than 10 years ago. It is for the younger audience. It simplifies the procedure and makes it very easy to understand. It's about 1.5 minutes, so I think I have that time. Sorry. The red is the Bankart lesion, lateral position. Scope posteriorly initially. Then switch the scope to the anterosuperior. There you have a beautiful view of the neck of the glenoid. Mobilize the capsule, abrade the neck. Of course, you'll pass the anchors in sequence, not all at a time. the suture towards the capsule, you retrieve it posteriorly. The plastic cannula goes at the back. And if there is no detachment of the labrum, you need not use an anchor to reduce the cost. Thank you very much. Thank you.
Thank you, sir. Thank you for the videos. Great, superb talk. May I request now Dr. Piper to start his talk?
Thank you very much for the invitation to participate in this meeting. I was going to give a short talk, and then I'm presenting a video of Latarjet procedure, open Latarjet procedure, but I must acknowledge Gilles Walsh because the video is actually taken from his technique. The video that I had for some reason became corrupted, and with the current shutdown, I can't record another one. So I'll use his training video and talk to that. But I'm just trying to work out where the share screen button is. Just give me one moment. Here we go. Share. Okay, can everyone see that?
We can see it.
So a lot of the material in this short talk has already been covered by the excellent previous speakers, so I'll move through it quite quickly. I think it's important to talk about the components of shoulder assessment, the different types of shoulder instability and the pathology that occurs, the results of non-operative management and operative management, and then the focus of this talk is really when I choose to do a Latarjet procedure. I've covered most of this information very well, so I won't spend too much time on the examination features, but this is what I just wanted to quickly talk about, the pathology that occurs. Now, with the vast majority of anterior instability, you have a combination of a soft tissue lesion with the labral tear or the Bankart tear, but also the reactive forces across the dislocated joint create the indentation, the Hill-Sachs fracture on the back of the humeral head. And this Hill-Sachs fracture can be what's called an engaging Hill-Sachs fracture. So when the arm is externally rotated into the position close to where it dislocated the first time, that Hill-Sachs fracture approaches the front of the glenoid neck, and you can see how easily it engages or slips over the anterior glenoid neck and redislocates. And this problem is exacerbated even with a very small Bankart fracture as you start to lose. Can everyone see my mouse as well?
Yeah, we can see it.
Great. So even if you lose a small amount of bone off the anterior rim of the glenoid, this Hill-Sachs fracture will engage at a much earlier stage, and therefore you have a problem of bone pathology getting in the way, which may interfere with a standard soft tissue repair. And when I sort of see these combined Hill-Sachs and glenoid rim fractures, I'm already starting to strongly lean towards performing a Latarjet procedure as opposed to a soft tissue procedure. Also, with capsular defects and Hagel tears, that they can also be managed with a Latarjet procedure as well. So I think it was Des mentioned that, that there's a high risk of damage to the axillary nerve performing an arthroscopic Hagel repair. You can do an open Hagel repair, but repairing the Hagel tear doesn't necessarily account for any capsular plastic deformation. But a Latarjet will be able to manage that Hagel tear. This is just plain X-rays. Here you can see a large Hill-Sachs fracture, another one on this X-ray here. So when you see these X-rays already, I'm thinking, should I be doing a Latarjet procedure? So I'm quite confident to do a Latarjet procedure, even if there is no glenoid bone pathology. I will do a Latarjet procedure if they've got a large Hill-Sachs fracture. Here you can see the in this auxiliary view, you can see the mechanism whereby the Hill-Sachs fracture here engages on the front of the glenoid and redislocates. Of course, MRI scan is useful here. We can see this patient has a Bankart fracture. And also CT scan is very useful as well. So you can see this is a locked dislocation, the large Hill-Sachs fracture. And also too, this is the 3D on-face 3D reconstruction views of the scapula with the humerus removed is very useful for assessing the degree of bone injury to the glenoid. Just a couple of quick operative photos. I think this is again covered by previous talks. This is a fairly straightforward labral tear. This is perhaps one that I would consider repairing arthroscopically, but this patient has a large Hill-Sachs fracture. So all of a sudden, thinking perhaps this should be doing a Lachaget procedure or something to address the bone anatomy as well as the soft tissue pathology. Some people have very little bone pathology, but in this case, I think this was an Alpsa tear, and after mobilizing, just completely destroyed capsule and labral complex. So this patient is not a good candidate, despite having no bone pathology, not a very good candidate for a soft tissue repair. And this is a Hagel tear seen arthroscopically. On the left, you can see a normal attachment, humeral attachment of the inferior glenohumeral ligament. This one has a large rupture. Very quickly, the results of non-operative management, I think we've discussed this already, but in the certain age groups and active young male population, they can have up to 90 to 95% recurrent rates, and in the general population, maybe closer to 50 or 60%. We've already discussed the results of arthroscopic versus open Bankart repair. I believe the results are very similar, but the overall failure rate of either technique can be as high as 15%. And I think Des mentioned that the incidence increases at 2 years. So many of the studies we look at have a shorter follow-up period than the 2 years. So it's important to look at long-term follow-up for Bankart repair. I agree with Des, the instability severity index score hasn't been validated outside of France, and I use it as a decision-making adjunct, I guess, but I certainly don't follow the numbers to the law as described by Boileau. He said that, I think I won't go through that, Des did that previously. So how does the Lachaget procedure work? Well, there's two real effects that I try to explain to my patients as to why I'm changing their anatomy. The first is fairly easy to explain. The piece of bone on the front of the socket increases the size of the socket and therefore helps prevent the shoulder coming out. But more importantly, this stops the Hill-Sachs fractures engaging. So as the patient rotates around, the Hill-Sachs fracture cannot engage on the front lip of the glenoid if there is a bone blocking that. But I think the more significant or greater stabilizing effect actually comes from the conjoint tendon. So the conjoint tendon is left attached to the tip of the coracoid process, and with the arm in the abducted and externally rotated position, the conjoint tendon is meshed with the lower half of the subscapularis tendon, and it creates what we call a sling effect. There's literally nowhere for that humeral head to translate into because of this tight mesh-like arrangement between the lower half of subscapularis, or the lower third, I should say, and the conjoint tendon. I previously used to do arthroscopic Lachaget, so this is an older talk, but here you can see the positioning of the graft. At 1 to 2 millimeters medial to the joint surface is fine, and then I would repair the capsule over the top. But and this is what a post-op CT scan looks like with the graft and the 2 screw heads. But now I actually I've gone back to doing open Lachaget procedures rather than arthroscopic. Very quickly, the complications. There's an estimated non-union rate of approximately 3%. But even if you diagnose a non-union, it may not be painful. It may not lead to recurrent instability and therefore may not require revision surgery. So I have had some patients that have not united, but have been satisfied with their results and have continued to leave them with a fibrous non-union, which has been effective to stabilize the shoulder. They do get a loss of external rotation because the subscapularis, the conjoint tendon is passing through the subscapularis tendon. that loss of external rotation is negated somewhat, or reduced, I should say, when you pass the conjoint tendon through the junction of the middle and lower thirds of the subscapularis. If you make your split in that junction rather than the middle of the tendon, you tend to reduce the external rotation stiffness. Removal of screws. Occasionally you need to remove screws for irritation. If someone does have persistent pain, often I will inspect the joint arthroscopically to make sure that the graft is not too proud, perhaps shave down a little bit of bone and remove the screws. And also inspect the joint for any evidence of arthritis, because arthritis develops in unstable shoulders. Some people argue it's because of the Latarjet bone block on the front does not have any cartilage. However, I think the more likely etiology of post-instability arthritis is the actual instability, its event itself causing the arthritis. Rehabilitation is, for me, it's very similar to my labral repairs. I leave them in a sling for 4 weeks. Remove the sling and start active range of motion exercises, a strengthening program at 8 weeks. They can return to non-contact conditional training at 8 weeks once they're starting their strengthening program, and return to most sports at 3 months, but collision sports 6 months. We'll save questions for later, and I'll quickly move on to the Latarjet video, and I'll talk to that. Oops, I just have to share the correct screen again, excuse me. So I was interested to hear, Des, that you no longer use a bump behind the shoulder. I might have to try that, but I certainly have been taught and always place a rolled up pillow slip, usually behind the medial border of the scapula, so that the scapula doesn't retract when you've got the intra-articular retractor in, either a Trullo retractor here or a Fukuda retractor. And the reason why I now have gone back to doing it open is because I can do it through a fairly small incision, about a 4 centimeter incision, starting at the tip of the coracoid process and extending distally. Deltopectoral incision, using the fat to identify the plane between the pec major and the deltoid muscle. Once I've established that plane and got down to the clavipectoral fascia, I place my finger in the wound and feel for the tip of the coracoid process. And the first retractor to go in is a retractor behind the coracoid process to lever up and expose the superior surface of the coracoid. We'll place that in a moment. So there you can see the conjoint tendon. The tip of the coracoid process is here, and a retractor is placed at the top of the cross of the top of the coracoid process. Here it is here, and it's a spiked homen, and it can be difficult, but you want to try and balance that on the angle of the coracoid process at the back, so you can see the entire superior surface of the coracoid process. Now the first dissection is to cut through the CA ligament, but like Gilles Walsh does here, I leave about a 1 centimeter cuff of CA ligament attached to the coracoid process, and that's what I'll use to do my capsular repair at the end of the procedure. So there you can see it's gone through the CA ligament and extending through the rest of the clavipectoral fascia towards the elbow of the coracoid process. That's the lateral side. The best way to access the lateral side when you're using a small incision is to abduct the arm and externally rotate the arm, and that will help expose the lateral side of the coracoid process. And then when you're ready to detach pec minor, you adduct the arm again, and that'll help move the soft tissue window to the medial side of the coracoid process so that it can continue your dissection. The pec minor muscle comes straight off the bone, taking care. The musculocutaneous nerve is not too far away. I leave some of the soft tissues attached, particularly laterally, because of the blood supply to the coracoid process. And then a right angle blade is used from the medial side to the lateral side to help protect the brachial plexus. And you're aiming to try and cut the coracoid process about 2 centimeters from the tip, or at the angle of the coracoid process. So once it's removed, just showing here the location of the musculocutaneous nerve. Once the coracoid's been removed, you often have still attached to the coracoid graft a little sort of angled bit of bone, which I quite like to see. That means I've got the best possible, the largest size graft. And you'll see that in a moment in this video. Can you see here? There's just, oh, went too quickly. I'll go back just a touch. Just here, he's got the angle of the, right at the base of the coracoid process. So that means you've got a good sized graft. Next step in the preparation is to flatten the undersurface of the coracoid process. And I'll just pause the video about here. There's a subtle difference between the American technique and the French technique. The American technique is to place the coracoid graft against the anterior glenoid neck with its inferior surface facing the articular surface of the glenoid. It's called the congruent technique, and that is, I believe the thought process is to match the undersurface, I guess, congruence of the undersurface of the coracoid graft to the slight congruence of the glenoid. But my teaching in France was to, in fact, place the undersurface of the coracoid against the glenoid neck, and the lateral part of the coracoid graft will be facing the same way as the joint surface. Because my teaching has been the broader surface attaching to the glenoid neck increases your union rate, and the bone facing the articular side doesn't need to be congruent or even level or with the articular surface. It's actually acting as a bone block. It's not actually trying to recreate some of the joint surface. So the subtle difference is that with the French technique, the screws would be traversing the coracoid in this direction, the American technique in this direction. This is obviously the French technique, the way I was trained. The undersurface is cleared of soft tissue, and then the right angle blade saw is then used to remove that little elbow of bone that remains attached to the coracoid graft and create a nice big surface area. So you can see here, you can use the right angle blade or a 4mm burr. But once the preparation of the graft is finished, you can see you've got a beautiful big surface area on the undersurface of the graft to heal against the glenoid neck. And that's been the way I've been doing it since my training in France. Next step is to prepare the graft with the inferior screw hole and superior screw holes. He's placed a Bristow underneath the graft so that the drill doesn't plunge through the graft and into the patient's skin. And that completes the preparation of the graft. That's ready to be placed onto the medial glenoid neck. That's the CA ligament to which we'll stitch the capsule at the end of the procedure. So that's placed. He's just now identifying the screw holes on the other side of the graft. Sometimes they can be hard to see because there's still a lot of soft tissue attached to the superior surface of the graft. 2 screw holes about 1 centimetre apart. So the graft is now moved medially, And the soft tissue dissection continues to expose the subscapularis tendon. These are the fibers of the clavipectoral fascia. You can see the subscapularis tendon underneath the clavipectoral fascia. And the tip that I was taught is if it doesn't look like muscle, or if it doesn't look like tendon, there's still clavipectoral fascia sitting on top. So continue your dissection until you see a nice clear muscle belly of the subscapularis. And with the arm and about 30 degrees of external rotation, you expose a nice portion of the muscle belly, and you can clearly identify the superior and inferior border of the subscapularis. And the split is between, it actually has 3 raphae. The split is between the middle and the distal thirds, or the lower thirds of the subscapularis. A horizontal split in the muscle, and then one using blunt dissection, but don't go through the capsule. So a horizontal split in the muscle, but a vertical capsulotomy. Once you've exposed the capsule and I usually feel for the medial or for the anterior glenoid neck, so a ray takes place within to help keep the subscapularis nerves, or nerves to subscapularis, protected, and a retractor is placed medially on the medial glenoid neck. Then in order to open the that's him placing the graft underneath underneath the retractor. In order to improve the view, further retractors are placed to retract the inferior subscapularis muscle inferiorly, and a sternum pin is used superiorly into the glenoid to retract the superior subscapularis. This is now a vertical capsulotomy. So the split in the subscapularis muscle belly is horizontal, but it does a vertical capsulotomy and places your intra-articular retractor in. This is a French retractor called a Trillo, I think it is. But in Australia, we more commonly use a Fukuda retractor. And it's that levering action of the Fukuda is why I use a bolster behind the medial glenoid neck, because without the bolster, I find that I'm really trying to, there's nothing holding the scapula, so you end up pushing the Fukuda too far. So this helps hold it forward. That's an anterior Bankart retractor going immediately, replacing that Homan. That gives a beautiful view through a 4-centimeter incision, a beautiful view of the anterior glenoid. He's done a vertical capsulotomy here, but the remaining capsule on the actual medial glenoid neck, or periosteum, I guess, needs to be removed to expose the underlying bone. So a little window of periosteum and capsule is removed. And this is where you'll see a Bankart fracture if they have one. That's a Bankart fracture, I think, in there. That Bankart fracture I remove, and it's demonstrating the labral tear, and this is the Bankart fracture here. That will be removed and expose the underlying bone, which then I prepare with a 4mm burr, although Jules uses a osteotome. So I use the osteotome to decorticate the anterior glenoid neck to create a nice healing surface for the coracoid graft to be laid down. But I use a 4mm burr in this location. You'll see in a moment. So the Bankart fracture has been removed, and you want a nice bleeding surface. And one of the mistakes, I guess, commonly I see with people doing the Latarjet procedure is to, like the inferior anchor on a labral repair, they're trying to get it as low on the glenoid as possible, but that's actually not how a Latarjet works. So Latarjet graft should be sort of at about from the 5 o'clock position to the 3 o'clock position, even a little higher. So the big mistake you can make with the Latarjet procedure is to place the graft too low, and then the shoulder will actually, if it's going to redislocate, will dislocate over the top of the graft. So what you want to do is place the graft a little bit higher on the glenoid and rely on the sling effect, the conjoint tendon meshing with the lower border of the subscapularis tendon to provide the inferior instability. So one drill hole's been made. He places a partially threaded AO screw into the coracoid graft, the inferior hole first. It's partially threaded so he can insert it all the way. And then that is now inserted into the inferior hole, only loosely to begin with. And then the graft can be rotated on the inferior screw to ensure that the graft is either flush or a little medial to the joint surface. You don't want it to be proud or jutting too far laterally and having it rub or impinge on the humerus. So not too tight on that inferior screw just yet. You can still now rotate that graft if necessary, but you're checking that the graft lines up with the articular surface. That's what he's holding there is the stump of the CA ligament, which will later repair the capsule to. He's happy with the position of the graft. He's now drilling the superior hole in the glenoid through the hole he's previously drilled in the coracoid graft. That inferior screw, he always uses a 35mm partially threaded screw, as do I, 34. And measure the top screw, and it's usually 2mm bigger, so a 36. If you're a particularly large person and that's 38 or something, you can, once this superior screw is in and stabilizing the graft, if you want to make the inferior screw longer, you can take that out and remeasure it. But usually always it's a 32 and a 34mm screw. Sorry, 34 and 36. And these are done just finger tight. You don't want to do them too tight. If you tighten them too much, firstly, the graft can start to medialize on the glenoid neck further, but if they're really over tightened, you can actually fracture the graft. The bone is not particularly hard, so just finger tight is plenty. This is the capsular repair at the end. Des, I think, uses suture anchors into the glenoid, which is another option. Or this technique I was taught by Jules and Laurent Lafosse for the open technique is sutures through the stump of the CA ligament and through the capsule. So use one Vicals to repair the stump of the CA ligament. Obviously, you need to remove the fukuda. Once I pass the sutures through the stump of the CA ligament, remove the fukuda, and then pass it through the capsule. You only ever stitch a fukuda in the shoulder once. So here you can see the two screws from the lattice graft, the capsular repair, and then the subscapularis split. So there's a superior subscapularis split still held by the Steinmann pin, and the inferior part of the subscapularis is down here with this is the conjoint tendon going over the top. Once all the retractors come out, the superior, don't forget the rotac, the superior and the superior 2/3 and the inferior third of the subscapularis will come together a little. And some people suggest closing the subscapularis split. I don't. I think leaving it open helps improve their range of motion. I just leave it open, and you can see there the two screws from the graft. And the wound's then closed with Vicryl and Monocryl. So apologies, that was not one of my original videos. I was sort of a bit last minute and I had to find one on the internet, but I think that demonstrated it's beautifully. It's much higher production quality than my videos anyway. Thank you very much.
Thank you, Dr. Piper. That was a superb video demonstration. Now, since we've come to the end of the talks, would the panel like to ask any questions to the other panelists before we start the questions from the audience? And I'd just like to have been informed that there are over 1,400 people logged in just now. That's a very good number. And we have lots of questions. Is there any questions from the panelists? Yes, sir. Desai, sir.
Okay, my question to the panelists two questions which are connected with each other. To Prof. And to Kalman, both of them. What is the incidence of lethargy in your practice? And would you do a lethargy in absence of significant glenoid bone loss?
I'll answer that first. Firstly, in my practice, I have a lot of tertiary referrals where they've had failed surgical procedures. So in my practice, about 25 to 30% of my instabilities are latter-shays. And yes, if I have a patient who's a professional footballer playing rugby league and he doesn't have a glenoid bone deficiency, I turn around to them and I say, how many operations do you want to have in your career on this shoulder? And for those people, I will do a primary latter-shay.
And I'm the same. It's 20 to 30% would be approximately how many latter-shays represent my stabilization surgery. But I don't do an arthroscopic Bankart repair or a latter-shay. I don't tend to do any other procedures such as remplissage or anything like that. So I'll use a latter-shay procedure for Hagel's, for large heel sacs fractures, and for recurrent dislocators with Bankart defects as well. So I agree, I'm quite happy putting a latter-shay in with a normal glenoid.
Again, a question for Prof is, would you not like to do an open Bankart repair in a person playing contact sports over lethargy when you do not have significant glenoid bone loss?
It's a very good question. I think that if the patient has had only a few instability events, there's not a lot of bone loss, I am happy to do an open stabilization, and I'm quite comfortable with that. But once they've had recurrent instability over a longer duration, firstly, it's unusual not to have some form of bone loss. But if you have that unique situation, sometimes you just need that belt and braces effect. So because we are dealing with high risk, high collision environments, they can't afford 2 seasons out of their sport if the arthroscopic procedure fails. So to be fair, I know latter-shays can fail as well, but if the latter-shay fails, that really has got to be quite a steam train that you've been hit by rather than by being hit by a smaller mini minor. So I think that reality is that, yes, I think I am happy to do an anterior open stabilization if there's no bony Bankart.
Thank you.
There are quite a few questions for all the panelists. There's one question for Desai sir. What's your opinion on Bankart plus remplissage versus lethargy in the Indian population?
Well, I am not a great fan of the remplissage concept. I disagree with the basic thinking, and my rationale is, in 2000, the world told us that if you have significant glenoid bone loss, soft tissue procedure will fail. And the world agreed with that concept. Now people tell me that you have bone loss on the humeral side, do a soft tissue procedure. So there is a contradiction in the basic thinking process. That's point number one. Number two, the incidence of a Hill Sachs, which is so large, without having significant glenoid bone loss, which means imagine a situation where the glenoid bone loss is say 8% or 9% or 10%, and you have a large Hill Sachs. That combination is not very common in my practice. Point number two. And if I had the common incidence, which is a significant glenoid bone loss and a relatively moderate or large Hill Sachs, then I would do a lethargy. So remplissage works well when you don't need it.
Professor Bankart, Dr. Piper, your thoughts?
Calvin?
Yeah.
I don't do remplissage. I agree with a lot of what Jesse just said. Yeah.
I would be very similar. I have done the occasional remplissage. I don't have confidence in it as a procedure, and I agree that biomechanically it's intuitively unsound. And the point that Dr. Professor Desai said is that you don't have people with significant Hill-Sachs defects that don't have glenoid defect as well. There's a little bit of a catch. Often, sometimes you look at and you don't see a bony Bankart. But what you do is if you do a 3D CT, you can actually see that that whole front edge is rounded off. It's almost like they don't have the slide, that the upward tilt of the slide, they sort of round off that edge. So you get this false impression that you don't have a bony Bankart. But in fact, what you've done is you've just eroded and rounded off that whole front rim, changing the whole mechanics of the construct. So I agree with Professor Desai that you go on and you do a lattice angle.
All right, there's one question for Professor Bankart also. Which group of instability patients, according to you, should never be operated? A contraindication, strict absolute contraindication.
For doing an open reconstruction?
Yeah, open or arthroscopic patients, you would say that you're not going to touch them.
By doing that, I don't want to do any surgery?
Yeah.
Oh, look, we all have a practice. We all have skeletons in our closet of patients we should never have touched. I think that my principle of instability, the first point I have to make is that a shoulder that is unstable before the shoulder has reached end range of motion. In other words, before you tighten the ligaments, the shoulder becomes unstable. You can't stabilize that. What we do when we're dealing with instability patients is we're stabilizing shoulders that at the end range come out. But if someone sits there with their arm in mid-range and starts creating party tricks of slipping the shoulder, you can't stabilize that. So the first point is you cannot stabilize a shoulder that dislocates before any ligament is on tension. Because that's a muscle imbalance, whether it be voluntary or involuntary, that's a muscle issue as well. The second group of people are that you do obviously need to have a compliant patient. And we do have those patients that they walk into our office and you really think of your worst enemy and you hope to send a secondary referral on to them. Yeah, there are those people there. Obviously, it's not a big group in my practice. Some people do have them, but I think the important thing is looking at that patient that is unstable without the ligaments being stretched. That's a group, and that's a whole variety of people, but that's the group I'm aware of.
Desai sir, Dr. Piper, your thoughts on this? Absolute contraindications for patients?
Is it for me or?
Yes, for you and for Dr. Piper.
Okay, so quite similar to what Prof. Bankart said, the voluntary dislocators, I feel all are not mad. There are two varieties of voluntary dislocators. One group with genuine psychological problems, I will not touch them. I will put them on rehab and refer to a psychologist. But there is a subgroup which is positional voluntary. Now that group is the one where they cannot dislocate voluntarily in any position, but it happens only in a particular position. Those I will put them on rehab, and if they do not respond well, I will consider surgery in that subgroup of voluntary.
There's one question for Dr. Piper. What is your cutoff for advising a Latarjet?
An age cutoff or?
No, the anatomical cutoff.
Anatomical. I'll do a Latarjet on normal glenoid. So I have done that in the past, mainly for the contact athletes. In fact, I'm sure Des will agree. A lot of our rugby players come in and they ask for the Latarjet procedure to be done instead of a labral repair. So I have no sort of cutoff in terms of amount of glenoid bone loss. I've got no hesitation doing it in normal glenoid.
Yeah, and there's a follow-up question on that, and your opinion on the congruent arc versus the classic Letarge. This one is also for Desai sir, both of them.
Yeah, so as I said in the talk, I think the congruent arc is not necessary, and I place the larger surface of the conjoint of the coracoid process against the glenoid to increase the healing surface. Classic technique.
Yeah. So my take on congruent versus the traditional technique, I do not believe that that piece of bone is meant to articulate with the humeral articular surface. If it was meant for that, that would be a disaster. Point number one. So it doesn't really matter congruent arc or no congruent arc. It's not the bone piece that really works in a Letarge. The Japanese guy, sorry, I forget the name, from United States, brilliant guy. He has evaluated how the Letarge works. And the main factor is the retention of the lower third of the subscap is how Letarge works. And then aided by the conjoint sling. But the bone itself is not the reason why Letarge works. In fact, most of that bone is going to disappear if you do a follow-up CT scan.
Okay. Another question for Des. How do you decide which patient you would open or do an arthroscopic anterior stabilization?
As I mentioned, I gave a number of factors that I discussed, which included the age, their sports, their collision environment, and other ligamentous factors. Reality is that if I have a patient that is minimally sportingly involved, they're female, they don't have severe ligamentous laxity, I can offer them an arthroscopic repair. I am happy to do arthroscopic stabilization for the first time, anterior dislocated, even in a sports person, before they've had the chance to get multiple instabilities to create plastic deformity within the capsule. But once they've had recurrent dislocators, I tend to move towards a stronger, more resilient type of reconstruction. So I use age, I use sex, I use the environment that they've got to go back into. And the first question you ask someone with instability in my practice is, what caused your instability? If what caused the instability is avoidable the next time, then you can readily do an arthroscopic repair if there's no major bony factors involved. But if what causes his instability is rugby and he's going to go back to rugby, then the person that made that shoulder is better than I am, and they tore apart that job to create an anatomical reconstruction for them to do something in an environment which is going to put them at risk, probably has a higher failure rate. So if the instability event occurred because of an unusual situation, then I'm a lot softer on saying, well, maybe we can do an arthroscopic repair. But if the instability occurred in a regular situation that they're going to go back into, then you have to be wary that you want a resilient repair for that.
Yeah. And one question for Dr. Desai, sir. What, according to you, is the need for a capsular shift in Indian patients?
You mean capsular shift as an independent operation or as part of Bankart repair?
I think the question doesn't mention that, but so you could give
So
on both.
So in my data, if I look at it, if I do 100 instability surgeries, 1 or 2 will be of the variety where there is no significant Bankart lesion, yet they dislocate. I'm not saying they are Ehlers-Danlos loss or connective tissue disorders, but normal people, but with very large voluminous capsule. And so that is 1 or 2% population of unstable shoulders. And I will first put them on a conservative treatment and try to rehabilitate them. And if they do not respond, then they become candidates in my practice for a capsular shift procedure.
Okay, there's one question for Dr. Gaurav. What, according to you, is the most important test for inferior shoulder dislocation on which you decide what needs to be done for the patient?
Well, in order to decide for the anterior instability, I would say that anterior apprehension and relocation has been proved to be most sensitive and specific. As I mentioned in my talk, the load shift test, you might hurt the patient or the patient might guard, but it is more of the interpretation which is more important for the apprehension and relocation, which is the apprehension, the feeling of apprehension that is coming, the head subluxating out and not the pain per se. So that's very, very important as per me. I would like to ask other faculty members what's their take in terms of, for beginners like me, what would be the single most test for the anterior, posterior and multidirectional instability?
Professor, you start first.
You would.
Sorry, you want me to start? Well, for me, certainly for anterior instability, regardless of what you're talking about, the most important test is the history.
Yes.
You have to listen to what your patient is telling you, because that will give you the clue. So I know that you asked what is the best test, but talking to the patient is the most important thing. Secondly, the next best test is to then examine them. And that's when you want to look at them. And I use the next step for me is this person ligamentously lax or are they not ligamentously lax? Because that will then drive me towards which test has what value in the light of what the constitution of their collagen is all about. The third issue then is then say, okay, for anterior instability, if I suspect from history they're not overly lax, anterior instability, yes, I think the apprehension relocation sign is a very good sign for helping that. For posterior instability, I think that I'm sort of torn between what they call the O'Brien's test, because it's not published as such, but the actual O'Brien's test is often positive in patients with posterior instability because their arm is across the body, it's internally rotated, you load them, and that's the position where if they've got a tendency to slip, they're going to start slipping out the back and they get pain with that. So for posterior instability, I actually use the O'Brien's test and secondarily will use the jerk test. And for multidirectional instability, well, multidirectional instability is multidirectional laxity with symptoms in multi-directions. So there can't be one test that tells you MDI. MDI is a lax shoulder, but it has to go in more than one direction. So you've got to confirm it with tests in a number of directions, whether it be Geiger's sign for the inferior, whether it be something for the posterior, whether it be something for the anterior. You're looking at a combination of all of those.
Dr. Piper?
Yeah.
To try and pick up what I find in my practice is that the load and shift test is useful in the MDI patient because it's usually not painful. So you can translate the ball out of the socket anteriorly, posteriorly, and of course you can examine the other shoulder too and compare the results of the examination on both sides. If you find that they're slipping out all over the place on both sides, you've got your answer. So I find that the load and shift test is helpful for MDI patients, usually because it's not painful. You can pop it in and they don't even feel it.
Thank you. Desai sir, what's your take?
Yeah, for me, the to diagnose and pick up posterior instability patients, the first is history, as Professor Bankart said. And what in history I am keen to know, as soon as the patient tells me that he had a complete dislocation, I almost certainly know that this is unlikely to be posterior, because the basic behavior of anterior and posterior instabilities is different. Posterior instability, you almost never get a frank dislocation posteriorly. So point number one, whenever a patient says that I have never dislocated, I only feel it's coming out, it subluxes and it goes back in, then my antenna is up to consider posterior as well. Point number one. So that to me is the most important thing, whether the patient has a full frank dislocation or not. If full frank dislocation, then it's most likely going to be anterior. Now, once the patient says that I have a subluxation, then I'm constantly looking for posterior instability. And then I will do the next thing, what Prof said is check for ligament laxity, because these patients often have posterior instability patients are likely to have some ligament laxity. And then lastly, I do a posterior jerk test. And I prefer to, the tip I can give you is, I prefer to do it in a supine position with the affected shoulder towards the edge of the bed, because that I don't have to bother about stabilizing the scapula, because it is, first of all, not easy to execute a posterior jerk test. Therefore, not in a sitting or a standing position, but make the patient lie down, and then suppose you're examining the right shoulder, then the left shoulder will hold the coracoid and the fingers behind on the scapula, and with your right hand, with the elbow flexed, you push it posteriorly, and then you relocate it. And that either pain or a feeling of relief when you relocate it is perhaps what works for me. And then the most important factor is a high index of suspicion. And this is one situation where MRI is extremely helpful.
All right. There's another question that has come, which is there are many sports in which there is no actual contact but are violent. For example, a young female playing badminton, where the force is pretty much, but there is no contact as such. What is your plan if they come as a first-time anterior inferior dislocators? Do you ask them to stop or change the sport, or how do you tackle such patients?
Sorry, who is it for?
For the whole panel. I
guess we'll let Prof go first.
Which prof? I was going to let your prof go first.
Because I'm not aware of violent badminton.
Okay, I think that the only violence in badminton comes when you lose the point and you want to throw the racket on the ground. Yeah, I think what we're talking about there is patients where there is a significant transmission of force across the shoulder, but it's not coming with an external factor. It's an intrinsic load. So we're talking about badminton, we're talking about overhead tennis, we're talking about handball, we're talking about throwing type actions. In that group of people, preservation of muscle balance and muscle control is critically important. They are a throwing athlete. So in that group of people, I would tend to be more conservative, firstly, moving away from open stabilizations and tending to go more towards arthroscopic stabilizations, because they need muscle balance. They don't, and you have to understand that when I attack a patient with a blade, I disrupt their proprioception probably for the next 6 or 12 months, if not longer, until they regain full proprioception. So we need to be aware that if we're dealing with someone who's got a sport that requires significant proprioceptive control of the arm, then we need to be as less sort of intrusive on the muscle balance that's going on there. So that's certainly a very good indication for someone you would consider an arthroscopic stabilization.
Piper and Desai, sir?
Yeah, so I divide sports into natural sports and unnatural sports.
The Australians don't consider badminton as a sport.
So to me, this is a natural sport. And in these patients, I agree with Prof. Bankart that you need a very good range of movement. They cannot tolerate any amount of stiffness, even slightly. So this is a case for me to do an arthroscopic stabilization procedure.
Dr. Piper?
I agree with all that's being said. But there's a distinction in Australia between contact sport and collision sport, which Des has spoken about many times. There's contact sports and then there's rugby. So it's the contact sports and the overhead sports grouped together. Rugby is 2 120 kilo men smashing themselves into each other. It's a different sport, different group of patients. So I agree.
Sports.
Unnatural.
All right. So for the follow-up of that, what would be your ideal position and duration for immobilization after reduction of an anterior dislocation? Because we have a lot of general orthopedic surgeons also who have logged in, who are not specialist shoulder surgeons, but do get dislocation shoulders.
Professor Desai, you should start.
Yeah. So to me, the post-op immobilization is only for comfort. So I will advise them a sling for a few days. As soon as they feel that the pain is lessened, they can give it up. So it is not a very strict immobilization for 3 weeks or 6 weeks. I don't follow that. It's only a few days. And they start after that, once the pain subsides, they go on a rehab program.
Gaurav, what do you do, Dr. Gaurav?
Yeah, but I think the question was more for the acute dislocators.
Yeah, acute dislocators, yeah.
So if it is for the acute dislocators, then there are studies saying that the immobilization should be in 30 degrees of external rotation. But even the internal rotation brace or a simple arm sling works better for me. And the older the patient, the lesser the duration of immobilization. For acute dislocators, I mean, with acute anterior dislocations which have been reduced. So I would like to have an opinion of Professor Boker and Kalman and even Desai sir. What do you all do for the acute dislocators? I mean, the patient has come to you, have reduced the dislocation.
Gaurav, by acute, are you meaning first time dislocation?
First time, yeah.
My answer remains the same.
All right. Okay.
I'm aware of IG Toy's work on immobilization in external rotation, but my worry is of patient compliance.
Yeah. All right. And
I would tend to agree with Professor Desai. I think that in Australia, to try and take a patient who's had an acute anterior dislocation and put them into an external rotation brace, compliance. If you read a paper by Hovalius, which he looked at management of anterior instability in the Swedish population, and he put them into a sling and instructed them to be in a sling for 3 weeks, 20% complied, just with a regular sling. So you can imagine what the compliance would be like with an external rotation brace, which is so inconvenient you can't walk through a doorway. So that's one issue. The second issue with Itoi's work is that was based upon doing an MRI, knowing that you reduce the glenoid labrum in external rotation, knowing the angle that it sits optimally at, and you need to put him into the external rotation brace in the beginning. There's no point having a patient 5 days after dislocation come into your office and then putting him into an external rotation brace, because they've already started to scar down the labrum wherever it wants to scar, whether it be on the neck, wherever else. So I'm not convinced that it's a viable option for me. In my practice, if I have a patient who's had an acute dislocation, I tell them, firstly, you've dislocated, we've put the shoulder back, your muscles, they're winded. They aren't going to act in the right way. The sling is to give you some protection until your muscles regain muscle control and tone to keep your shoulder in, which is what you rely upon to keep your shoulder reduced. As soon as you've got muscle tone, the sling is irrelevant. I don't have an period of immobilization. I simply immobilize them until I'm comfortable. 1, they've got no discomfort, and 2, I've got the sense that they're regaining their muscle tone. Now, that could be a matter of days. In some people, it could be a matter of a week or 2, but that's purely done empirically for the principles of protecting the shoulder when the muscle is atonic from the dislocation and not needing the sling in that position once they've got muscle tone to support the shoulder anyway.
Okay, so we've got like a huge number of questions, but we are going to, because of some time constraint, we are going to actually not take all of the questions. But there is another question for Dr. Bokar, probably from Australia. It says, for rugby players or collision athletes, would you consider doing a Latarjet as a primary surgery or initial procedure for instability?
Absolutely. Absolutely. I often talk with my patients, and as Dr. Kalman mentioned, patients from rugby teams now walk in and they listen to what you've got to say, and if you don't say Latarjet, they walk back out again because they've already talked to their friend. In rugby, the most important referral practice we have is the locker room when they have their shower afterwards, because they look at the other shoulder and they say, where did you get that scar from? And said, oh, I had a Latarjet procedure 3 years ago and I have no problems. And then they're going to say, well, I want that if I'm going to have an instability issue. So yes, quite commonly we'll do a primary Latarjet with, as Kalman said, even without bone defect in that high risk, high collision environment, which is not normal sport. It's abnormal sport with abnormal personalities.
Dr. Piper, you would concur with Professor?
Oh, absolutely, yes.
Yeah, and Dr. Desai, with reference to Indian patients?
No, I tend not to do Latarjet. The only kind of contact sports patients I've had is wrestlers and kabaddi players. So I have quite a few of those. And I have done a Bankart repair in these if there hasn't been a significant glenoid bone loss. Say if they are 15% glenoid bone loss and below that, then I have done an arthroscopic Bankart repair in those wrestlers, and they have gone back to wrestling. And my logic is that until this wrestler dislocated his shoulder, what was keeping it stable? And if I can reconstitute that, I expect that it will remain stable.
All right, we have another question for Dr. Gaurav, and we'll be concluding the session soon. What's the best test for detecting the internal impingement and a subscapularis tear?
All right. So O'Brien's test is a wonderful test just to detect whether you have any signs of impingement or not, apart from Hawkins-Kennedy test. So in the O'Brien's test, as Professor Boka mentioned, you have to ask the patient to forward flex the arm, and with 10 to 15 degrees of adduction and internal rotation, ask the patient to flex the arm more against resistance. If the patient complains of pain on the top of the shoulder, it's more of the AC joint, whereas pain inside the shoulder or some of the inner aspect could be because of some internal impingement. Whereas the Hawkins-Kennedy does the same thing, internal rotation, again, passive internal rotation. So that's for internal impingement as per me. And for subscapularis tear, as I mentioned earlier, the bear hug test has got much highest sensitivity and specificity. I would like to ask other panelists and faculty members about their take on this or their opinion on this. What, according to you, is the best test for internal impingement and for subscapularis?
Yeah, I use knees impingement test, and for subscapularis, definitely the bear hug test.
Yeah.
The lift-off test is very difficult. If someone's got a painful shoulder, they often can't even get their arm into that position to perform the lift-off test. So I don't find that's very helpful at all. For subscap tears, definitely the bear hug test.
Right. Professor Boka?
Well, the question was internal impingement, not rotator cuff impingement. Internal impingement occurs in abduction, external rotation, and it's the pinching of the part of the suprainfraspinatus tendon and the posterior labrum. So I don't have a good test to determine internal impingement, but it's a symptom that occurs in the throwing athlete with the maximum external rotation. You want to look at the GERD and see if there's internal rotation deficiencies. You use that to help guide you with that. But the question was internal impingement, not cuff impingement. And that's a very difficult test. And not a lot of the tests are accurate for it. And it does tend to overlap with the relocation apprehension sign, but you don't have so much apprehension. You have pain, which is decreased with your relocation test. But again, it's not specific. It's a very non-specific thing. And most times when we talk about diagnosing internal impingement, we go in with suspicion and we've either got an MRI with gadolinium that shows the frame that we want to look at, or we've found it in arthroscopy and we say, oh yeah, that's what his ultrasound was. It was internal impingement.
All right, we are coming to the end of the talk. We have one more question. As I said, we've got a lot of general orthopedic surgeons also logged in. So the question is for all the panels, do we, from Dr. Rajiv Sharma, do we need to do an MRI in all shoulder dislocations, or CT is good enough for planning of surgery?
I can answer. I guess I would prefer a CT scan for a patient where I'm planning to do a Latarjet over an MRI scan. So sometimes if a patient presents with bone defect or bone abnormality on an MRI scan, I'll then refer them for a CT scan. If I can see any sign of bone defect, I'll refer them for a CT scan before I get an MRI scan. If it's soft tissue lesion only, then I'll make my decisions based on the MRI scan. But as soon as I have a concern about any bone lesions, then I'll have a CT scan, and I don't need an MRI scan if I've got confirmed bone lesions on a CT.
I suppose that the reason for the question was you have cost constraints I can do one test. Which one should I do? And I think that Kalman addressed that quite nicely. I think everyone gets a plain X-ray. That's straightforward. If my X-ray shows bone damage, then probably the best way to go is you're dealing with a mechanical problem that's going to require bone augmentation. I would go with a CT or a CT arthrogram. CT arthrogram doesn't let you do 3D reconstructions, but it does give you some indications of capsular damage and other damage that can occur with that. If I don't see a lot of bone damage on the plain X-ray, I would tend to go to MR arthrography and use that as my alternative. In our country here, we do have the luxury of being able to sometimes do both. But if you don't have that luxury, use your X-ray to guide you. If there's bone deformity, you will get more mileage out of a CT scan. It'll help you plan what you want to do. And it's your call whether you put in dye or not. If you don't see bone deformity, you probably will get more benefit from an MR with arthrography, with Galileo.
Desai, sir?
Yeah, so first of all, try to understand the question that when you have a first-time dislocation in our country,
Yeah.
patient comes with an X-ray. Now, the reason why we want to do any imaging investigation, CT or MRI, is because we want to pick up that bony Bankart lesion. That's my logic number one. So, interestingly, by the time a patient comes to me in my practice, they've had not one but two MRIs already done. And therefore, what I'm left with is asking for a CT scan. But what I want the audience to know is that if you have some clue on plain X-ray of a suspicion of a bony Bankart lesion, then ask for an imaging, further imaging, and which would be ideally a CT scan. Because those bony Bankarts, I like to fix them soon. And that's the reason why we want any further imaging.
All right, there's one last question for Dr. Kalman. Does age play an important role for Latarjet? And what is your take, Professor Boka?
Absolutely. In the older age group, I'm less likely to do any stabilization surgery, but absolutely less likely to do a Latarjet procedure. I have heard of them being done in patients up to 70 years of age, but that would be a very rare occurrence. I think a lot of, if you have an elderly patient with an unstable shoulder, you need to think about secondary causes of instability, such as a massive rotator cuff tear, and perhaps be treating a rotator cuff tear rather than any labral lesion or consider a Latarjet procedure. In terms of a lower age limit, I've done patients as young as 16.
In my practice, I would tend to agree with Kalman. I don't think there is an age limit for Latarjet. We have a very unusual animal in Australia. It's called the middle-aged athloid, the middle-aged man who thinks he's an athlete and he isn't. And so it is not unusual to move towards doing a Latarjet procedure in a 35-year-old who's still playing rugby. I had a friend of mine at 45 was still playing semi-professional rugby in one of the lower grade teams. So we have this beast that people in this generation tend to be far more physically active at a far greater age than when I look at my parents' generation, where my father at the age of 55 behaved like an old man. I mean, 55 here, people are still out competing, doing lots of activities in sports. So I don't have an age limit. I agree with Kalman. I have too seen people inappropriately having Latarjets at 70 years of age and not looking at why they're unstable. And there are reasons why the older patient is unstable recurrently. And Kalman mentioned it very clearly. Rotator cuff tear. By the time you're over 40, if you have a first-time dislocation over the age of 40 or 45, there's a 50% chance you will have some form of cuff damage that might need to be addressed at the same time. So we do need to look at alternate things. The youngest person I've done a Latarjet on is about 14.
All right. I would like to apologize to all the people who've sent questions there. It's impossible to take that in triple digits. So it's impossible to take all the questions. And we've already with popular request, gone 1 hour over our scheduled time because everybody is just logged in now. Now, I think we have 1,500 plus people logged in. I would like to thank all the panel members for giving their talks and sharing their views with us, especially to to Professor Bankart and Dr. Piper. It must be very early in the morning for you guys. Thank you very much.
No, it's in the afternoon. We're in the afternoon.
Yeah, we've come to the afternoon. From morning, we've come to afternoon. Thank you so much, and thank you, Dr. Gaurav, Dr. Desai sir, Professor Bankart, Dr. Piper. Thank you very much, and
thank you for having me.
Thank you very much.
Thank you. Hope to see you soon again.
Thank you very much, Gaurav and team. Very well organized, and congratulations to you. Well done.
Yes,
Thank you.
Thank you.
And thank you,
Thank you, everyone.
Thank you to our guests from Australia. Thank you very much.
Thank you.
Bye-bye.
An honor and a pleasure.